You're listening to Season 2 of Medscape's In Discussion series on idiopathic pulmonary fibrosis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Jeff Swigris, pulmonologist and professor of medicine at the Center for Interstitial Lung Disease at National Jewish Health in Denver, Colorado. Dr. Swigris specializes in the clinical care of patients with interstitial lung disease and directs research centered on how interstitial lung disease affects how patients feel and function in their daily lives, how to best measure those effects, and how quality of life may be improved for patients suffering from interstitial lung disease. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for you as healthcare professionals.
Hello, I'm Dr. Jeff Swigris. Welcome to Season 2 of the Medscape In Discussion podcast series on idiopathic pulmonary fibrosis. Today, we're going to discuss the topic of genetics of pulmonary fibrosis, and we're so lucky to have my guest, Janet Talbert, with us today. Janet is a senior associate in the Department of Pediatrics in the Division of Medical Genetics and Genomics at Vanderbilt University Medical Center. She also serves as a genetic counselor in the Division of Pulmonary and Pediatric Genetics in Nashville, Tennessee. Janet, welcome to the podcast.
Thank you, Dr. Swigris. Thank you for having me on this podcast. I'm really honored to be here.
Janet really is one of the experts in the genetics of pulmonary fibrosis, so we're very lucky to have her here today. Before we get into the nitty-gritty, Janet, tell our audience how you became interested in genetics and genetic counseling, and particularly in the area of pulmonary fibrosis.
If I had to encapsulate that into one idea, I would actually say it was pulmonary fibrosis itself. And I had already been tinkering with the idea of becoming a genetic counselor. I had a background in working in genetic laboratories and research and even forensics. And I was applying to the field, and while I was waiting, I actually started working at National Jewish Health in Denver, Colorado on a study for familial pulmonary fibrosis, or FPF. And I was drawing pedigrees, and I was taking family histories, and I couldn't really answer everyone's questions about their risk or what it was going to mean for them if a gene was found. And I realized I was actually doing the work of a genetic counselor without the proper training. So that propelled me and sealed my decision to go into that field.
And we're really, really lucky you did. I mean, Janet has improved knowledge in our field on the genetics and really advanced our understanding and helped so many patients and families and practitioners like myself to give us some knowledge that patients and their families are looking for. Patients often will ask, why me? Why did I get this? And in my simplistic view, being a clinical investigator, not a genetic researcher or a basic scientist, I tell patients and their families that the way we think about pulmonary fibrosis now is that there's three things that come together to allow pulmonary fibrosis to develop. One is aging. And that's not to say all patients with pulmonary fibrosis are old or that as we age, you are going to get pulmonary fibrosis. But there's something about the lung getting older that predisposes to the development of fibrosis. There's something about the lung getting injured that predisposes to the development of pulmonary fibrosis. And in my simplistic view, I say the genetic programming, the way the lung in an individual patient is programmed to respond to that injury. But we want to hear a little bit more about the genetic programming. And so talk to us, if you would, Janet, about our current understanding of not this broad view genetic programming, but the actual genetic basis of pulmonary fibrosis.
Well, the current understanding is really just like the disease itself. It's very complicated. Namely, it's not a single gene disorder like cystic fibrosis or muscular dystrophy. It's not even a single class of genes, but rather a conglomeration of various types of genetic risk combined with or without environmental components. So genes have been discovered that strongly run in a very small subset of families. Pulmonary fibrosis can also cluster in families without a genetic identification, without a gene that we know of. Or it could just be common genes that we all share that predispose but may not directly cause, but may contribute, along with some kind of environmental exposure. And on top of that, you mentioned aging. Our genes break down as we get older, just like a car. And we have to keep our car healthy, right? So for us, that's exercising, eating right, staying away from toxic environments. And some of the genes we've even discovered are involved with the aging process. So that makes sense as well.
It seems like this field is rapidly evolving. I mean, I remember when I first started out, we had no clue about the specific genes that predispose or increase risk of pulmonary fibrosis. So talk to us about the last decade and some of the specific genes that have been discovered that are now linked with pulmonary fibrosis.
In the last decade, and maybe even the last 2 decades, a couple of things have happened. We've mapped the human genome. Our technology has become faster, quicker, cheaper even to run genetic testing to discover more genes. Then what we've done by studying families, enrolling families into trials and looking at their DNA, we've discovered several genes and really 2 pathways that seem to strongly run in a very small set of patients and families. We don't have an explanation for every family. One of those pathways is the telomere pathway involving our telomeres, which are involved in aging. They're prematurely aging is what's happening. The other pathway is surfactant, which typically we see in childhood, and we think of childhood interstitial lung disease is a little bit different and separate than the adult onset type. There are some genes that can run in families, but it's a very small subset of the subset of families. And then we've found through genome-wide association studies where we compare healthy people, or we think they're healthy, to people with IPF or pulmonary fibrosis. When we try to see what's common and what's not, we find certain genetic changes that seem to coincide more with the patients with disease than patients without. But they are common, meaning even healthy people are walking around with those changes and they will never get pulmonary fibrosis. Those are called common variants. This, all in the last decade, I would say, has really ramped up, and we've learned these things, but we don't have 100% of our patients covered from a genetic standpoint.
Can we circle back around to the telomere story? And the way that I think of telomeres these are sort of caps on the end of our chromosomes that, as our cells divide and DNA replicates, makes copies of itself, these telomeres are supposed to stay a certain length relative to our age. They get shorter as we age. We have an enzyme program that is meant to keep our telomeres a certain length for our age. And if the telomeres are inappropriately short for one's age, that is associated with certain abnormalities, one of which is lung fibrosis. One, I guess, is that the right way to think about that? And two, can you speak more to the telomerase pathway and this telomere pathway in terms of its link with pulmonary fibrosis?
Yes, everything you said was very well put, so I'll jump ahead. The telomere length does shorten over time. An older person's telomere lengths in their cells are going to be shorter than a baby's telomere lengths. That's supposed to happen. It's like a reverse growth curve. And its link with pulmonary fibrosis was discovered in other premature aging syndromes where we would see bone marrow failures and liver cirrhosis of unknown cause, bone fractures, osteoporosis, certain head and neck cancers, immunodeficiency. And these were all linked by these genes that were in that telomerase pathway. And telomerase is an enzyme, and an enzyme is made by genes. DNA is our code of letters, and it spells out for certain genes to create proteins, in this case telomerase. Telomerase carries out a function, which is keeping that process intact and regulated over time. When there is a pathogenic variant, which used to be called a mutation, but the language has changed to pathogenic disease-causing a variant change in a gene, that process is disrupted. There are a host of genes, probably up to 16 now, that have been found across these telomere biology disorder spectrum. And pulmonary fibrosis is in that spectrum. Some people with telomere biology disorders and pathogenic variants are affected at a younger age. The older ones tend to get the liver cirrhosis or the pulmonary fibrosis diagnosis, but it can span the lifetime. And so when you take a family history, a lot of times I will ask about those spanning from childhood all the way to older age.
That's really important information for us as practitioners. So you taught us when you were here at National Jewish Health, when the telomerase story was really just being discovered and being solidified, that if we have a patient with pulmonary fibrosis, we ought to be asking questions about their history and their family history. And you mentioned a few of them, but I want to make sure that for the practitioners out there, we hear from the experts. So we should ask about premature graying of the hair. And I would love to have you comment on that, because I've heard different age cutoffs for that, about any issues with liver, any issues with bone marrow, and I say funny anemias or low blood counts, non-traumatic fractures, head and neck cancers. Are there other things that we ought to be asking? And then circle back, if you would, Janet, to the premature graying of the hair.
Yes, premature graying of the hair is my least favorite question. I'm only really impressed if it's under the age of 30, especially impressed if it's like in the teens or early 20s. There's so many other reasons to have gray hair. There are other genetic conditions, or it could run in families. It could be separate from the telomerase pathway. So one doesn't always equal the other. And I think because it's so easy to see, it's an easy go-to, but they don't equal each other. I've had families with telomerase mutations that don't have premature graying. So definitely something to keep in mind, to really think about that age of onset. And I think if I even go back in my own history, I could have said I had a gray hair at 28 years of age. But bone marrow failures, liver cirrhosis, alopecia, the classic triad was oral leukoplakia, dysplastic nails, and a lacy renticular pattern around the neck. But most people don't even have that. They might present only with pulmonary fibrosis. Because your whole genome is throughout your entire body, these genes are expressed in different tissues. And therefore, for one person, it could present as pulmonary fibrosis. Another person, it could be myelodysplastic syndrome. Or it could just present as pulmonary fibrosis in a family in isolation. So it's important to recognize that there are other extrapulmonary manifestations, but the lack of them don't exclude the possibility of a telomerase mutation. And even in our sporadic patients, we can see the same type where one person has IPF, but if you start looking at their family, you see some of these bone marrow failures, liver cirrhosis, other indications that might enrich for a gene mutation in the family. And about 10% of the time, we can find it even in sporadic IPF.
I get the question a lot. Patients will come in and say, how did I get this? Or what did I do? Or what tests can be done? So I'd like you to comment on that. If I have a patient who comes in, they're diagnosed with what looks like idiopathic pulmonary fibrosis. I take a family history. Obviously, my family history is not going to be nearly as extensive as yours. There's no suggestion of telomerase abnormality based on those questions that you just mentioned, but the patient says, I want to get genetic testing, or should I get genetic testing? How should we respond to that patient?
That's a great question, and one I get often. I think if they desire genetic testing, that should be an option for them, and explain the limitations of actually finding something. So earlier I had said it's about a 10% pickup rate in sporadics In families, it's about 30%. And the more of those extrapulmonary features you have, it can go up as high as 80% chance to find a pathogenic variant. So I think part of counseling is explaining to them the limitations of genetic testing and how we don't know everything right now. Some of the tests that we can do won't answer that question, but it doesn't mean that it doesn't have a genetic component, that we've ruled out the genes we can currently test for. I've been doing this for 21 years. And in those 21 years, we started out with 2 genes and then 5 genes. And now we're up to about 13. And we continue to find new genes as we do studies and we learn more about the genome and what these genes are doing in these pathways. Also, our technology, even though it's cutting edge, we only look at a certain portion of genes when we do testing. We think it's the important parts. And we could learn in a year or two that there is a very remote place in the genome that we didn't know existed that happens to impact the development of pulmonary fibrosis. And then we have to go back and retest people. So genetic testing is, to me, sort of like radiology. It's a snapshot in time. And then our technology increases, we get better, we get more refined, we learn more, and we can take another snapshot at a different time.
I think one thing you said I want to reinforce and highlight for the audience here. If a patient wants genetic testing and you decide to pursue genetic testing, I think it is critical that a genetic counselor be involved because, as you said, Janet, you have the expertise. Patients need to know what we can actually test for, and patients also need to know the implications of the results. Either, okay, if you have genetic abnormality or X, Y, or Z, this is what it means. But if you don't have any identifiable genetic abnormality at this time, this is what it means.
Yes, absolutely. A patient should have that conversation with a genetic counselor or someone knowledgeable or who feels like they have that expertise, like a physician who specializes in genetic forms of pulmonary fibrosis, because there are a host of other questions that come behind that. If we were to find a genetic cause in a family that has implications for other family members, what can we do? What does that mean for their children, their grandchildren, their siblings? So it takes someone to think beyond just the patient in front of them, to think of the patient as also a family, because genes are shared by their family members. And that takes some special conversations as well. And then we think about clinical utility. And at the end of the day, what we'd like to do with genetics is have some action to take when we find this. And right now that is very limited for pulmonary fibrosis. So we can find the information, but we don't know exactly what to do with it at this point. And that can cause some areas of anxiety or even depression or feelings of not being in control. Some people find it empowering too, but they should be in the care of people who have an expertise, like a medical geneticist, a genetic counselor, or someone who's in this field specifically with genetic knowledge.
Again, just to reinforce that, this is a very individualized decision and one that should be made with an expert because, as Janet said, some patients are going to want to know, other patients are not going to want to know. Many of my patients who would like genetic testing say they're doing it for family members and so forth, but it's a very individualized decision and should be made with the experts. Can you just talk to us about a vision for moving forward, how genetics and genetic studies might contribute to the development of therapies for lung fibrosis? You know, where do you see avenues for advancement in our field and where we might be going over the next decade or two?
Well, first of all, I think that this is a very under-tested population. The more we test our patients and their family members, the more we're going to learn. There's been some hesitation for testing because of that lack of clinical utility or maybe cost, which has come down immensely. And we can't do anything about the fear if someone doesn't want to test, we support that as well, especially in my field of genetic counseling. But the more we test, the more we're going to learn, and we're going to drive knowledge and possible therapies. Some of the common variants could be used as targets in clinical trials. If we know these pathways like telomerase or surfactant, we know what enzymes are not being produced enough, and maybe we could supplement those. The field of medical genetics has been doing this for a really long time, since probably the 1970s, with metabolic disorders. And now that's moving into cancer therapies and neurological therapies. So I see that we could do that with pulmonary fibrosis. Pulmonary fibrosis and the genetic underpinnings are no different than those of Alzheimer's or cancer or neurological disorders, which are all other diseases of aging. Those are farther ahead than us. And some of that is because the genetics hasn't been as emphasized. So I think if we start testing more, even clinically, not just in a research setting, we can start to open up the knowledge and maybe create clinical targets for those genes.
Is genetic testing covered by insurance? And if it's not, and patients are paying out of pocket for the 13 genes or however many we can test for, what's the cost going to be for a patient?
Genetic testing is not always covered by insurance because of that lack of clinical utility that they see. However, there is becoming more clinical utility. For instance, the lung transplant teams are starting to utilize telomere length and telomere pathogenic variants as part of their workup, mainly for post-transplant treatment and immunosuppression regimes. Because of that, there are insurance companies that may be able to pay. I can't speak per insurance company. But if a patient does have to pay out of pocket, we can actually test for panels of genes less than $500. It depends on the lab. And again, that's why a person with expertise in genetics, like a genetic counselor, should be involved so that they can pick the right test for the right patient. And also we take that into account, cost, as one of those limiting factors.
So Janet mentioned the lung transplant field is testing telomere length because there are emerging data to suggest patients with really short telomeres, and the cutoff varies less than the 10th percentile or maybe less than the first percentile, are at increased risk with immune suppression of bone marrow abnormalities, if I'm not mistaken. And we're even seeing this creep into the ILD field a little bit, at least raising the question of the safety of immunosuppressive therapy in patients with shorter telomeres. So stay tuned for that, as that story is really emerging.
In addition, identification of pathogenic variants in genes for other family members who are then at a predisposition could implicate those patients to seek care earlier and possibly catch fibrosis before it begins, even though having a pathogenic variant does not guarantee that they will develop pulmonary fibrosis or any of the other extrapulmonary manifestations. It confirms their risk in the family, and then we could possibly screen them. For instance, there are studies out there that are looking at first-degree relatives of familial pulmonary fibrosis patients and scanning with CT scans and breathing tests to detect early disease. If we knew their genetic profile and knew they carried a pathogenic variant, that would mean we would need to follow them closely clinically as well.
That's really important information. And I know that you aren't necessarily the one who's ordering CAT scans and breathing tests, but certainly are in discussion with researchers and potentially practitioners who are. So right now, June 2024, what's the practice if I have, let's say, a first-degree relative of a patient with pulmonary fibrosis? This first-degree relative has a genetic variant that predisposes them to the development of lung fibrosis, but they're currently asymptomatic. What should we be doing for them? Or what have you seen some of the practitioners in the know, so to speak? What have they been doing?
There are no established guidelines. However, some practitioners would do baseline screening, say maybe after age 40. And again, that's anecdotal. There's no guidelines that state that. But we actually don't know when this disease starts. And that's part of our clinical trials of looking at these family members asymptomatically and seeing if there's early disease there and then watching them. Because even if they have that pathogenic variant, due to reduced penetrance, they could have an attenuated form, or they may never develop pulmonary fibrosis in the first place. So they may screen them with pulmonary functions and baseline CT scans and do that every several years.
So for practitioners who do not have a genetic counselor on campus or one that they have access to, should we just find a center and send those patients, or are there other resources that you might recommend for folks who aren't near an academic center, for example?
Yes, the field of genetic counseling lends itself well to remote and telehealth options. There are several telehealth companies across the U.S. who are licensed in every state and can do telehealth either by telephone or video and work with that patient to pick the right tests for them, order it through their local physician possibly, or even order it for them and get results back, because everything can be done remotely with genetic testing. In addition to professional bodies like the American College of Medical Geneticists, the National Society of Genetic Counselors, and the American Board of Genetic Counselors, where you can locate individuals with genetic expertise.
That's great information. Thank you, Janet. Today, we were so lucky to have Janet Talbert with us to talk about the genetics of pulmonary fibrosis. Just high-level recap, there are genetic variants that we know are associated with lung fibrosis. Janet reminded us of two critical pathways, but the field is certainly emerging, and it seems like more and more genes are being discovered every day. The two pathways are the telomerase pathway and the surfactant pathway. Most importantly, work with your genetic counselor. For patients who are thinking about genetic testing, in my opinion, should never be done without the help of a genetic counselor, because it is really important for patients and their family members to know what we can test for, what we cannot test for, and what the implications are for either a positive test finding a genetic variant or a negative test not finding genetic variant. Janet, thank you so much for being with us today. We really appreciate your knowledge and expertise.
You're welcome. Thank you for having me. It's been a pleasure.
To the audience, thank you very much for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on idiopathic pulmonary fibrosis. As always, I'm Jeff Swigris for the Medscape in Discussion podcast.
Thanks for listening to Season 2 of Medscape's In Discussion Idiopathic Pulmonary Fibrosis podcast series with our host, Dr. Jeff Swigris. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on idiopathic pulmonary fibrosis.